see everybody and great to be here today. And it's my real privilege to introduce to you Ms. Dawn Skelton. She is an exercise physiologist and is currently professor in aging and health at Glasgow Caledonian University. She's an academic with a strong interest in exercise program implementation and in encouraging less sedentary behavior and increased light physical activity in frailer older people. She was a co-author on the World Falls Guidelines and is currently chair of the British Geriatric Society Rehabilitation Group and a member of the OHID National Falls Prevention Coordination Group and Four Nations Falls Prevention Group. She chaired the UK's Royal Osteoporosis Society's Statement on Exercise and Osteoporosis and the Older People Panel for the UK's update of the Physical Activity for Health Guidelines, and she received the British Geriatric Society Marjorie Warren Lifetime Achievement Award for her work in translating falls prevention research into practice. So welcome to you, Professor Dawn.
Thank you, Gregor.
It's just great to have you here today.
Just introducing me.
Yeah, and how are things there in Glasgow? If you were to look out your window, what would we be seeing?
I have blue skies and sunshine, which is not that common in Scotland, so it's a welcome start to the day.
Well, very good. Well, we planned it that way for our global cafe, just to give it a little extra lift. Well, tell us, Dawn, a little bit. Tell us first. Tell us a little bit about yourself. How did you come into the field of aging and exercise?
Well, it started actually off with my having, very luckily, having 4 grandparents as I was growing up. And my 2 grandmothers both lived to 98, but they led very different lives. One was very active, and the other wasn't. And I noticed quite early on the effect that had on their quality of life and their engagement. I applied for a PhD in this area, in exercise and strength training with older adults. And it's really nice to see on this call the lady that facilitated me doing that, which is Elizabeth Mills. So thank you.
Right.
And Elizabeth at that point was heading up research into aging, which was one of the first funders to consider aging as a priority in research. So I worked very, very closely with Elizabeth for many years. And so really it was experiencing the effect of physical activity on my own grandparents that made me decide this was an important area to go into.
Okay. Wow. Interesting. Well, I have to just interject here because I, as everybody I think knows, we had some extremely exciting news that has just very exciting since the Madrid Declaration, MIPA in 2002, that on Wednesday morning in the UN Human Rights Council, governments decided to start drafting a UN Convention on the Rights of Older Persons. So this resolution was adopted. It's very excited. It was adopted by consensus to creating a new intergovernmental working group to elaborate this legally binding instrument on the rights of older persons that is going to affect all of us in the future. It's a legal binding document, and congratulations to all of you who have been working hard to move that work forward. And you know, I can't help but it's sort of affecting all of my thinking at the moment. So I'm gonna, maybe a little later we can get back to that and maybe talk a little bit about how having a legally binding instrument like that with the UK as a signatory can affect and implement, you know, the actual practical implementation and effect of frailty and fall prevention. I think there's some interesting parallels to explore. So wanted to just state that as we kick off this morning. But first, why don't you tell us a little bit about why is frailty and such an important area to pay attention to? And what are the risks if we don't pay attention to it?
Well, the biggest risks are to older people themselves, because unfortunately we are providing lots of medications and healthcare to help people live longer, What we're not doing is giving them the ability and the skills to live well longer. And so what we're seeing is a larger proportion of people becoming frail and having a long period in dependency. That is, never mind costly for healthcare systems, it's costly to the individual and their family and their friends and their carers. And just to give an example, in the UK, older adults attend their GP on average 8 times a year, and they are nearly all frail. So the ones who are not frail don't go near the GP. And this is a really important point. Frailty has a strong relationship with physical activity. So people become frail for a variety of reasons. It might be that they have diseases that have affected their ability to participate. It may be that they have disabilities that mean they can't participate. But on the whole, we unfortunately tend to do less as we get older. And the old adage, use it or lose it, is really important. And so people are, in effect, allowing themselves, in a way, to become frail, probably because they just don't understand there's something they can do about it. And we need, I think, as it's our ethical and moral duty to support them in ways in which they can be more active, which will help preserve function.
Okay, okay. Well, from a life course approach, I guess we can obviously start preparing for older age with good physical exercise and use it or lose it mentality. Is it ever too late to start? Is there a point where we say, oh well,
Definitely not. And actually, that was what my PhD was about. It was looking at whether we could do strength training in over 75s. Now, we're talking 30 years ago, and 30 years ago, we didn't know that we could do that safely. There was some early work, but it was essentially quite new that you could do high intensity strength training with a 75-year-old and reverse aging by 20 odd years with a 12-week program. So,
is that right?
yes, that's that good. I mean, strength training in particular is the keystone to frailty, because if you haven't got strong muscles supporting joints, etc., you don't feel stable to engage and balanced to be engaged in more moderate to vigorous physical activity, which has other effects on cardiovascular system and that sort of thing. So I think one of the key things here is the understanding that even if you're 100, you can increase strength in your muscles and it will still benefit you. The issue of most people is they don't understand that is possible. They're worried about if it'll hurt, and no is the answer if you build it up slowly. And this is where your potential issues about ageism come in, that we quite often wrap people up in cotton wool and go, oh, but they get tired, so we'll sit them down and we'll do gentle exercise. Actually, if we want to have a real effect on physical function in a timely manner for older, frailer people, we need to work pretty hard, actually, in the early stages to make sure they've got the efficacy, the ability to do something, and to support them to keep doing it, to adhere to it. And so it's in a way, it's got to become as important as cleaning your teeth or having your green veg, is doing your strength and balance exercises every day. That would make a step change difference to how we age.
Interesting, interesting. Again, I can't help it. I want to just tie in a little bit here of a convention. A convention has accountability mechanisms. So countries have to report. Signatories have to report and commit to what's enshrined in protecting the rights of older people. So it makes me wonder about could some of these mechanisms be leveraged to mandate, evidence-based fall prevention programs that combat some of these ageist assumptions about physical, limitations in older adults. I wonder, oftentimes even older adults themselves are the worst culprits of reinforcing these own ageist ideas, and even our own physicians, our families. So I wonder about, from a policy level, what kind of mechanisms might we do to try to take apart some of these assumptions about physical activity in older
I mean,
adults?
there's a couple of things in there that jump out that I've been involved in this last year. We can't in the UK even map where all the falls and frailty services are. There
Mm,
isn't even a list of those anywhere. We have to do freedom of information asks for various health authorities and NHS trusts to see whether they've got them in place and whether they offer exercise and what they offer. So we also, OHID, that's the Office of Health and Disparities in the UK, they have produced, for example, a quality marker set for strength and balance programs available to older people. And they are asking, but it's not, it's voluntary. They're asking for these councils to feed back on how many classes are available or how many one-to-one sessions, what services they have in place for older adults to take part in strength and balance training. And so those sorts of things to be mandated and have in effect an update each year. The other thing is that our falls and frailty services, about half are actually in the community, not in the National Health Service. So they're commissioned by different people. And again, it's to ensure that we've got pathways between those, a seamless service for the older adult. And I think also the importance of the quality of those. So
mhm.
we have just started an audit of physiotherapy services and what they offer in terms of an exercise prescription for older adults with frailty. And we are finding, for example, that they are wrapping them up in cotton wool. There's no equipment, there's very little progression. So we need a good mandate would be what have you got in place to ensure the quality of the services being offered to frailer older people? And can we even find them?
Well, and how about programs and services like the exercise rehabilitation program? That maybe tell us a little bit about that, and is that a widely available resource?
Well, there are two main ones in the UK in particular, but also I see that Claire Robertson's on the line as well. There are and so even in New Zealand as well, we have two main programs which we know work. They don't just reduce strength and don't just improve strength and balance, which are risk factors. They also have been proven to reduce falls. So we have a Targo, which was developed in New Zealand, and that actually is almost worldwide now. There's certainly the research is worldwide now. What I don't know again is how much these are commissioned in real world. And then one that I was involved in, which was FAME, Falls Management Exercise. And it's called that because you can't stop all falls. We all fall. I think if I asked everybody in the room now to put their hand up if they've fallen in the last year, probably a third of us would put our hand up. Falls happen. What we want to do is make sure people can get up again. So FAME has a big focus on retraining getting up off the floor so that if you don't injure yourself, you can just get up, look embarrassed and walk off like we all do. And FAME is widely available across the UK, certainly, and it's now starting to become available in a couple of other countries. Otago is widely available in Spain, it's widely available in New Zealand. I'm pretty sure it's widely available in the US. So there are a variety of these. The issue is to get the accurate messaging, because a lot of people say we have programs that prevent falls. What they've done is they've put together a seated exercise program that has a couple of TheraBand exercises in. There is no evidence that seated exercise reduces falls. It can help with frailty, potentially, but in terms of falls, you need to be on your feet, and you need to be
Right.
practicing feeling wobbly. So it's if everybody got this idea that there is a continuum of exercise, we have to offer primary prevention. We have to get strength and balance into people's brains that it's important. And any activity that improves strength and balance will help prevent that first nasty fall. But if somebody is falling already, it again, to me, it's immoral not to offer a treatment that we know works. If you come to the drug world, if somebody is having cancer treatment or something else, they get given a pill that's had multiple testing, that you know the dose, the frequency, and the progression that that person needs to be on. And medics follow that. But for some reason, exercise isn't given that due importance, that there are rehabilitation programs which are treatment, and there are prevention programs that help prevent in the first place.
Mm-hmm. Interesting. Interesting. Well, maybe could you have any share any like a personal story or an example of of older adults who've successfully reduced their fall risk through some of these interventions, or do you have a?
Yeah, I've got a couple of, I'll keep two. I just want to mention two. One, which was starting with somebody in a care home environment. And at that point, I was actually working in care homes trying to implement exercise programs. And this particular lady got literally wheeled in her wheelchair. She was actually still asleep in the chair when she got wheeled in. She had 24-hour oxygen, so she had her oxygen on the back of the wheelchair. And it was really hard to engage her. To cut a very long story short, because we're talking 9 months to a year later, where she was doing a twice-a-week class with me, delivering it. She was not on oxygen anymore. She was walking around with a Zimmer frame, not in a wheelchair, and her daughter was able to take her out shopping again. So she went from someone that and no oxygen, by the way, during the day. She just had it at night. This step change improved her quality of life and improved her interactions with her daughter to be able to take her out of the home at weekends, etc.
Mm.
Then there's the lovely Violet who took part in FAME in a community setting. She arrived with a Zimmer frame, had required a transport to and from because she couldn't get on public transport and she didn't drive anymore. And she had had a hip replacement and she was really never regained her mobility properly after that. 9 months later, again, we're not talking short term, we're talking longer commitment to exercise with progression. She was able to rejoin a walking football program. She always loved watching and playing when she was younger. And so she joined a walking football program. She used to wear her hip protectors just in case, because you can buy sets of hip protectors that you can wear, for example. But again, an example of someone who thought, and most people think that frailty is a one-way street. You can only just get worse. But actually, with good exercise physiology and making sure somebody has a progressive overload in terms of challenge to the muscle and to the brain, because it's the brain that keeps you upright, then you can see massive step changes in people's ability to do things.
So that's it sounds like behavior change has a pretty big impact on reducing risk. Can you say, would that be true?
Home exercise booklet handed out and then expecting someone to do it will not work. You need to give support. You need to, people have different motivations. They change if they've not been feeling unwell, if there's been a death in the family, if they've become a carer. There's many reasons why people's motivation to keep doing things changes. So to have a contact that just cares and contacts them every now and then and says, are you doing your exercises? Can I help you with anything else? Is there anything else I can get you involved in? We know that group exercise works better because there's that social environment and that peer support, but not everybody wants to or can get to those. So we do need to support people to exercise in their own home as well. But we can't just imagine they're going to do it by giving them a couple of exercises in a booklet. That's not going to work. So we need to think, like we all have dips in our motivation of things we know that helps our health. The same thing is happening with a frailer older person. In fact, probably more so because they have a perceived level of energy of what they can put in to things. And so we need to support them as much as possible. But you can make you can help somebody massively improve their quality of life with exercise.
Another one of the things that I know we all have experienced, but also particularly in low and middle income countries, is the lack of data and aggregated data between the say 5 year segments over the age of 65, or in some places it's even it's only up to age 49, and then somehow or other you don't exist anymore.
Yeah,
The
absolutely.
the convention is going to enforce the accurate collection of data that countries will have to report on, which is very exciting, which will then inform these potential policy developments and building frameworks within countries. So I wonder, for you who's already on the ground and has the evidence and experientially, what kind of policy changes or public health initiatives do you believe could make significant impact on fall prevention for older adults?
Well, one of the key things that's happened is the World Falls Guidelines doesn't give an age that you start thinking about assessing and managing falls. And that's deliberate because we're starting to see evidence, for example, and I see in the chat someone's mentioned Parkinson's or dementia. Those people are at higher risk of falls at an earlier age, potentially. So someone who's got early onset dementia, or someone who develops Parkinson's, or has had a stroke, or has got type 1 diabetes, all of these will increase your risk at a potentially earlier age. So risk should not be based on age. It should be based on literally ability. So can you maintain upright balance if you get a knock, for example? I think in terms of what would make a big difference is services who are considering frailty not having an age boundary, it being relevant to an individual's function and ability rather than an age dependent thing. We know, for example, that up to 20% of 40 to 50-year-olds fall, and it's bigger in men than women. Whereas once you get to the 80-year-olds, it tends to swap over and more women fall. So our services potentially need to look at certain groups earlier. So if you've got Parkinson's, the likelihood is you're having a yearly checkup with some medic somewhere. So they should be being asked about falls at any point, because then they could be moved into a falls program to support. We can't, if somebody's got a progressive neurological condition, whether it be dementia, Parkinson's, or motor neuron disease, for example, or MS, we can't stop all those falls. But what we can do is help people manage them better, be more resilient, stop reducing their activity as a concern about it, make sure they can get up off the floor. So, in terms of still reducing their chance of becoming frail later, we just need to offer those services to people when they need them, not at an age cutoff.
I guess maybe you could say a word too. What about environmental modifications? Like policy around age-friendly environments, cities and communities, housing adaptations. What role can they play in preventing falls among frail older adults, particularly maybe in low-resource settings or environments?
So we know that falls, funny enough, a lot of the injurious falls actually in frailer older people occur in their own homes and in their own safe, what they consider as a safe environment. But what we do know is that there's some research that if occupational therapists go in and have conversations with them about that loose rug, that poor lighting on the stairwell, having a handrail on the stairs as you first go down, are important, and they help reduce the chance of falls in the home. Outside, what we want is physical activity friendly environments. So everything from in the parks, having some strength activities, some strength kit. So you sometimes see outdoor exercise equipment, for example. And if there was something there to suggest, because older people do use parks, so can we make more use of those? Not necessarily in very wet, cold regions, but potentially elsewhere. We also know that frailer older people stop walking outdoors because there's nowhere safe for them to sit, or they can't find somewhere to have a rest en route. We don't want too much street furniture because they're having to navigate too much things that they may fall over. They'll avoid busy environments, they'll avoid messy, dirty environments, and they'll avoid environments that they feel unsafe because of crime. So giving them safe indoor walking areas in countries where the weather is either too hot or too cold to be outside is important as well. And I think if we have a better age-friendly city environment or age-friendly environment, we will, with that, increase our physical activity or see an increase in our physical activity levels. It's the issue, of course, if the country is very hot, you don't want to be out walking in midday heat. And so there's a variety of things we need to do to support older adults to be active in more extreme environments as well.
An interesting topic here in the city where I live, in Ottawa, Ontario, Canada, has been the access to public restrooms. That
Yes.
People can't. They don't want to leave their homes because
Yep.
Well, let's move to a couple of questions here. Shmuel always is ready to kick us off, and he hasn't let us down again this week. And he asks, so how, according to your opinion, governments and authorities can support in practice change behavior for improvement, preventing falls among older adults, including older persons from poor and low socioeconomic groups of our population?
I think they could help with campaigns. So whether they be on TV or in social media or a variety of other routes. But I think, when I was young, there were campaigns about how to cross the road safely, about the importance of, they weren't all the time, but they had big reach. And so I think that would help. I think, for example, in the UK NHS, we had some work back in late 2009, 2010, actually, basically saying we will not allow ageism within our NHS. Even if you're 90, you can get a hip replacement, even if you're, and so they introduced that, so it became law not to be ageist, if you like, in our NHS system. But I think one of the key things here is, and it's not the right time in culturally or sort of environmentally in terms of money, but we need more money into services that support, let's face it, a quarter of our population. And in some countries, it's even higher than a quarter are that older older demographic. So it would be really nice to have better care services that support remobilizing people rather than just making sure they've had their pills and have they got dressed. So actually involving care systems that support maintenance of independence rather than, I think, quite often feed dependence. So
Right.
I think those sorts of things would be really helpful. And just a very small example, but we at the UK are about to update our physical activity guidelines again. We had them in 2011, we had them in 2019. There's never been any marketing of them. So health professionals, believe it or not, up to 20% have never even heard that we've got physical activity guidelines for health. And yet they're the ones that are meant to be encouraging us to be more active. And the public, it's way lower than that. So
Oh,
it's all very well producing guidelines, but if we don't actually disseminate that,
yeah, yeah.
that requires money and expertise, then I think we're not doing anybody a good service.
No, that's a great point. Great point, Don. Um, I wonder, Mark Venning asks if you could speak to the connection between falls and dementia
Yeah.
and some strategies to address that. And Mark has shared that his mother, who had dementia, had 3 bad falls. So he's coming from a place of his own experience. What do you think?
The evidence base, sadly, is not as strong for people with moderate to severe dementia. In mild dementia, you can use the same evidence base because nearly all the interventions that have worked with people with intact cognition work with people with mild dementia. At the point at which they start moving to more moderate or more severe, we can support in a variety of ways. It's still important to maintain activity, and that requires quite often some extra support of the family. So they will support people to remember to be active and to do activity and exercise. At some point, though, in the dementia trajectory, people will become it'll become very obvious they can't take a backward step and they're not very good at taking side steps. They start taking very much smaller steps and staring at the floor. At that point, they're at very high risk. And so I think, and it's harder to engage them in exercise as well, because at that point, the brain is not making quite the right connections. So at that point, we need to start thinking about things like hip protectors, that if they fall, they then potentially won't fracture the hip, which is the worst outcome apart
Yeah,
from death, of course. Um, if you can, and actually, we know people with dementia, if they do have a fracture and they end up in hospital, that changed environment and changed health patterns can actually give a step change worsening in their dementia as well. So it's all about then preventing the fracture, even if you can't stop the falls. Obviously, falls alarms are helpful. That's reactive, that's not proactive. I understand that. But essentially, I think it's much more about engaging the family to help that person maintain their physical activity as long as possible. So
yeah,
that's the way I would go. There is nothing as yet that we've found in the evidence base that's effective to prevent the fall in people with severe dementia. But interestingly, and this is anecdotal, but you'll find very, very broadly that you can sort of put people into people that don't sit still. So their dementia means that they're constantly on the go, constantly looking for something, constantly doing something. They rarely fall because they're physically active, and the brain is having constantly to keep them upright because it's getting lots of practice. The person who sits and stares is going to be the faller. And so it's that person that you need to try and engage in more activity. The brain's very good at remembering, muscle memory. They won't necessarily remember they've done the exercise after the session, but the body has still improved in physiological ability.
That's really great. Well, Dr. Asha Vijay Rao, I think you're speaking right to his point, but I wonder if Dr. Rao, you might like to expand or ask a focus question, asking, can we have some tips on managing falls? Would you like to expand on that question, Dr. Rao? Oh,
I'm
sorry.
here.
Okay, thank you.
Thank you for this thing, John. I was attending yesterday a workshop on Parkinson, and they said dance therapy and music therapy also helps in stabilizing people. This was organized by Jaslok Hospital in India. So anything like that you will suggest will help falls.
Yes, in terms of the research to prevent falls, dance and other things don't have a strong evidence base. What they do have an evidence base of is improving strength and balance. And I'm again making a distinction deliberately. So if someone is not yet had an injurious fall and is not a regular faller, dance, funny enough, boxing has also got a high evidence base so for the men with Parkinson's, boxing also has a very strong evidence base for improving strength and balance. So yes, all of these activities will keep someone engaged. If they like dance, they'll do it. And that's the key, isn't it? Because I've seen another question about how do you engage someone who's not particularly active and has got away from being active. The thing to do is to find something that they're interested in, and they're more likely to start with that. And then you could say, do you know what, if you added to this an evidence-based program where we just focus on the strength work as well, that will help even more. So I think, yes, Parkinson's is progressive, and at a certain point we no longer can make a big difference with falls. But for example, FAME and Otago has been looked at in research with people with Parkinson's, and it does reduce falls in the earlier stages, that's for sure. So any activity within Parkinson's, you're after something usually with a beat, because then they can follow that, because often you've lost that ability to plan movement, and a beat can help, whether it be a metronome or a dance move or a sound in that respect.
Would you say?
Thank you very much.
Yeah. Thank you. Sorry. Yes, that's excellent. I also wonder, Elizabeth Mills asks, is Aquafit good exercise for maintaining balance? And I wonder if maybe it's not. Well, I don't know. What do you think?
It is, because I'm doing a big research study on that right now. So good timing, Elizabeth. So I'm looking at Aquafit at the moment. We've done a feasibility study as to whether we can get fallers, people with high risk of falls and frailer, into the pool to do strength and balance exercise. And the answer is yes. Some of them did require hoists, so they didn't have the strength to get in and out of the pool. We had to support people walking to and from the pool because of the risk of an unsafe slippy pool. But the early stage, it's a feasibility study at this point, so it's not powered for effectiveness, but early stage, their balance and strength got better than the matched group that were doing land-based exercise. Now, the reason potentially for that is that once they're in the pool, they're not worried about falling over at all. So they work way out of their normal base of support. Water in itself is resistance to work against. So the more work you do, and of course, if you then add pool kit in the pool, foam and that sort of thing, you can increase resistance. So again, for people who have a history, what we have found is that the people we've recruited into it have all been they liked swimming when they were younger. We haven't recruited anyone that was never been in a pool before. So again, back to choice. You know, somebody loves being in the pool. Wouldn't it be lovely to be able to offer them the choice of pool-based, water-based falls prevention exercise?
Yeah, excellent. A real motivator. Well, that David Richardson asks, is there much research on the most effective motivators for older adults who may not, especially for those who may not have been active throughout their lives? So, you know, you're suddenly needing to become active. What's the evidence telling us the best motivators?
Yeah, the best motivator is to have a long, decent conversation with them about what things they currently do to be active. They may not even be realizing. It might be playing with their grandchildren. It might be actually they really enjoy walking around the garden centre. So, okay, this is great. How can we build on this? And them also understanding, because quite often if they've not been active their lives, and that's not unusual in an older population because it's more recent that we've got into exercise for recreation. They don't know what it is you're asking them to do. So little videos of classes and activities so they can see people like them engaged in taster sessions, which they don't have to pay for, because are you really going to pay for a 12-week program when you've got no idea what it is or whether you're going to like it? So, and actually having some empathy. So not expecting someone to go from 0 to, you know, an hour and a half a week. It's not going to happen. We need little increments. And one of the things, and I saw that Lana put the note into the chat earlier, during COVID, I helped set up a movement snack. So it's 15 minutes, 3 times a day, 7 days a week, and it runs even on Christmas Day, and it's still running 5 years later. We've had so many people that started doing that purely because they couldn't get out and they felt socially isolated, so they joined, who have since then gone on to join all sorts of activities because they suddenly went, wow, just that 15 minutes, I can feel so much better just a few weeks later. And so it's that understanding that if you don't know what you don't know, you're not going to try it. And so I think we just need to be more ambitious in our views about how we can spend time with someone so that we can find that hook. And for many people, they want to be active for their grandchildren, for example. So give them some examples of ways at which they can do that, which means they'll enjoy their time with their grandchildren more.
Oh, there you go. That's it. Find the outcome that was meaningful for them. Do you want to spend more time with your grandchildren? Well, then you should do this and this.
I had a very good conversation, Gregor, just a few weeks ago with a gentleman in my local village who I was trying to support because I can see his walking is getting really quite bad. And his main motivation was he finds it difficult to stand at the bar and order his pint. And I went, right, okay, that's fine. Let's work on that. And so, yeah. and not being judgmental.
Let's go practice, shall we?
Yeah, let's go practice. But it's really important that we have those conversations. Sadly, most health professionals have got a time slot where it's all about doing this, filling out the paperwork, and they don't have those time for those conversations. Right. So we need to have other people doing that, maybe.
Yeah, I just C. Freeze makes the interesting observation that the dominant rationale for supporting people to live at home is to keep people out of long-term care or save money. But staying at home and the everyday demands for activity may also be really beneficial in reducing risk instead of, in some cases, potentially an understaffed or very busy long-term care setting where people are just left to be sedentary. That's a really interesting observation. And second to that, if you'd comment, what about community-based initiatives that help people reduce falls and can help people stay integrated in their community? I guess they're kind of a similar idea.
So I think that's the best place to do that because we need a long dose. We need a decent dose of exercise before we know we prevent falls. It's not a quick thing. And most rehab services don't have long enough with an individual to provide enough of a dose to make a difference. So almost all falls prevention exercise programs anyway will run in the community. I would say that the biggest issue we have even then is that when people leave those, they tend to just stop because they think they're sorted. So it's again having that conversation saying, do you know what? You need to carry on with this. It's important. We have social prescribers in the UK, and so we're spending time training them up to understand and have conversations with people, start them to try and be a bit more active, and then hopefully transition them into programs that work. I mean, an example is if you see if someone will short term commit to adding an additional 10 sit to stands a day. So just every time you stand up in a day, stand up, sit down, do it again. Lift your body weight again a second time. That in itself, if you're frailer, will make a step change difference into your energy levels and ability to get out of a chair within weeks. And so sometimes it's starting them off on that and then going, fabulous, look how much you've improved with that. Let's now work on, but it's having that contact with somebody that understands. And I'm going to be honest, care staff generally don't have an understanding of physical activity and health. And they're more worried about a fall. They don't want a fall happening while they're looking after someone. So quite often they're not supportive of people being active because they don't want to have a fall and have to deal with the family and everything else that goes with that. So we need a lot of training in those areas, I think. And in an ideal world, we need, as I say, to bring on board friends and family. Don't just leave it all to the health professionals. Those friends and family will become carers, likely, of that older person at some point. And if we can get them involved in activity, it means they're less likely to require care when they're older. So we're back to campaigning the importance of strength. It needs to be as important as cleaning your teeth.
Yeah, I'm still waiting for that. Someone's got to come up with it. It takes a village to raise a child. It takes a village to, I'm not sure what I'm always trying to find the right statement that sounds right, but it's something we have to do really together in community, isn't it?
In my local village, we have volunteers that deliver strength and balance programs to our older population because our nearest evidence-based exercise programs are 48 miles away and there's no bus.
Wow.
So there is no way that those people can get to the evidence-based programs, in the city up the way. So what we've done is we've trained up local volunteers in just a small selection of strength and balance exercises that they can do every week with the local village. And what's interesting is if at any point one or two of them can't do the class, some of the participants have gone, well, I've been going long enough. I can always do the class this week. So we've built up a little community of people supporting. It would be really good if we could get more of that. It doesn't mean I want to take away the evidence-based delivery by someone who knows what they're doing in terms of exercise progression. But if we haven't got those available, we just need to raise awareness of safe technique. And I noticed that someone's put a comment in the chat. Safe technique is important because if you do a sit to stand badly, you put excess pressure on the knees and the lower back, and you increase falls risk. So it's just simple things about where you place your feet and what position you put your weight in, and when you do that, it can make again a huge difference on whether it's comfortable to do a sit to stand or not. And also what exercises you might do to strengthen around a knee that needs a replacement, because that can quite often be an issue. But if you do strengthening work around the knee, you can often reduce the pain and actually potentially reduce the need for the knee replacement. So we need to empower our local communities more to support active aging.
Yeah, and I'm looking forward to hearing more about the pub mobility exercises that maybe you may be working on. A note here also from Veronica from Southern Africa, from Malawi, points out that falls is a big issue for her as well. She had a patient 100 years old, and she fell 3 weeks ago. And even though for the past 12 years she's been doing lots of prevention exercises, she has a question on calcium supplements or food rich in calcium for bone health, or maybe other supplements. Do you have any comments on that to sort of
obviously a falls injury can be beyond a fracture, but Fractures are an interesting one, because if we're not doing enough strength work, we will lose bone density quicker with age, because it's the muscles pulling on the bone that stimulate the bone to produce more bone. So strength training and in being on your feet, some impact is important. In terms of supplements, yes, obviously vitamin D and calcium are very important. And interestingly, in places like Australia, where they slap not to stop yourself burning, the creams, you can actually end up with higher levels of vitamin D deficiency, because the minute they don't go out in the sun at all without sun cream on, and that stops you turning the form of sun into an active form of vitamin D. So I think the other main thing, though, about muscle is muscle requires protein. So a protein-rich diet's really important for older people. As they get older, they tend to avoid dietary products because they're worried about cholesterol. So they're cutting out the calcium. They're quite often having a lot of pills, and especially if they've got multiple conditions, those pills with the water you take for taking them actually fills up their tummy, so then they don't want to eat something. But you need protein in particular, and you need good vitamin D in your diet to ensure good muscle function. So I guess that's the key thing, is exercise on its own is fine, but you also need to have a good diet, as good as possible, and you need to make sure you're outdoors in daylight for a certain amount of time to make sure that you convert that food stuff into an active form of vitamin D that the bones can use.
Wow, that's a great takeaway. Vitamin D, calcium, protein, and sunlight.
Yep.
Wow, that's fantastic. Thank you. I put it in the chat. Well, Don, you know, we're coming to the end of our session here. I wonder if you have anything that you'd like to say or close on, something for families, for caregivers, or anything you felt we didn't get to today that you think is really important to say, or last word with you.
My lovely friend Elizabeth has just put something in the chat, which again is stimulated something else I wanted to just remind people of. The single biggest cause of functional decline is a hospitalization for any reason. So when we go into hospital, we stop moving. We're not encouraged to move. And when you're frailer, you lose muscle very quickly. You can lose up to 1.5 kilos of muscle in a week of bed rest. Which is why it's really important that if you're going to visit your relatives in hospital, you don't just sit by the side of the bed and have a cup of tea or a biscuit with them. You take them for a walk, because the chances are they've not been supported to mobilize the whole day, because the nurses are very busy. And again, they don't want falls on the ward either. So again, in the UK, we have a campaign called End PJ Paralysis, PJ meaning pajamas. So your bedwear, in effect, because many patients, when they go into hospital, will stay in bed the vast majority of the day, even if they didn't need to be. And I'll again give you an example. I had a student once that had some accelerometers on a group of people in sheltered housing. And we were doing sit to stand, adding these 10 sit to stands, and we were looking at the effect that might have on function, which, as I said, was positive. One of those people fell and broke her wrist and went into hospital. She was kept in because she had very high blood pressures. They kept her in for 3 days. Her movement activity, which still wasn't brilliant beforehand, she was beforehand spending about 70% of her day sitting, her waking day. In hospital, she spent 98% of her day sitting. She'd only broken her wrist, remember, not her hip. She went home and it took 4 weeks before she got back to about 70% of her day sitting. So it encouraged her to stay sedentary for quite some time after her hospitalization. People increase their fear of falling when they're in hospital as well. And that again might be because staff are going, oh, wait for me and press the call alarm so I can go with you to the toilet. People end up going, oh, I must be quite at risk if they're waiting for me to, I've got to press the button to. So we're constantly, if we're not careful, we're increasing a person's perception of their risk, which means they decrease activity, because older people in general associate a fall with activity, which is somewhat true. But what they don't get is by reducing activity, they're just going to increase their risk of a fall because their function will decline. So we need every contact with an older person to be supportive of physical activity and particular strength work. And every professional and person in touch with them. If everybody said the same message all the time, it would become culturally normal to see people in parks using that outdoor strength equipment or people joining groups. We just need to overcome this cultural issue that because you're frail, you sit. That's the biggest thing I think we need to do.
Well, thank you so much, Professor Dawn. It was just fantastic to have you today. Such an interesting topic and such an incredible time for us as we have had the convention, or the drafting of the convention, passed by consensus, and how that's going to affect us all in the future, and affect these very issues, on the ground issues. It really rubber hits the road when we talk about creating structures and policy and around enforcing good practice, evidence-based practice, good data, to be able to support issues like frailty and falling for the future. So amazing topic. Thank you so much for taking your time to be with us today at the Global Cafe, and to everyone else who's been participating today. Thank you all.
Cheers.
Over to you, Luana.
Yes, I just want to introduce next week's session. So for next week, please join us as Dr. Andrew Butson will have a conversations around brain health, reframing expectations from patients and caregivers. So we hope to see you all next week.